Good evening, everyone. Oh, Maria, you've connected to the audio. Hooray. Let me pause start the recording again. Hey, good evening, everyone, and welcome to the next MFEN lecture. We are very, very lucky tonight to have Dr. Barbara Needs lecturing to us. Barbara will introduce herself, but I need to say Barbara was a past president of FEN. And this is her first outing on the MFEN programme for us, but she's going to come back again. She's already booked in for another session, which is really good. And Barbara is the oldest members of FEN, seen it through a lot of ups and downs. And her specialist subject is law. So I asked her if she would do our session this evening about consent treatment, and then the opposite of it, really, refusal of treatment. The reason this is such an important topic in emergency care is because of all those self-discharges. We cannot just rush along and stop speed and think that everybody is just there being a widget on our production line. We do have to engage with the patient and make sure that they understand what we want to do, why we want to do it. And they are given an opportunity to consent. And equally, we can't just go, well, that's fine. If you want to leave, sign here. So we really need a bit more detail on that. And that's why Barbara's lecturing for us tonight. Barbara, the floor is yours.
Oh, thanks very much. And I get my Sunday title and everything, which is wonderful. But thanks for inviting me to speak. As you said, Jeanette, I've been with FEN for quite a number of years now. And I think this is probably the first time I've actually done a law session with them. It's always been emergency sessions before, so this is quite interesting being asked to do it, but absolutely delighted to do it. And what I thought the best way to do this is to talk about consent and the framework of consent and the issues around that, which I think is an important kind of background to what we're going to talk about later on, of how do we make decisions in emergency care about consent or refusal, at the counter side of that. And I hope that our discussion will stimulate some thoughts amongst anybody that's present and anybody that's kind of following it up later on, really. So the first slide, the next slide that I move on to is actually to just put it in the context of the legal perspective on that. So slide 2 is actually about the Human Rights Act to begin with, on refusal of medical treatment. If we could just move to that one. You could share slide 2. I think you're muted, Jeanette.
I am, so you didn't get any background noise. My end says I'm screen sharing the Human Rights Act 2000 rights relevant to medical treatment.
That's it, yep. So, right. But that's not come up. We're still on 1 for some reason, what I'm seeing.
Okay, this could be fun. Right, well, on the basis that it's recording what's on my computer rather than what's on yours,
okay,
we'll press on.
All right.
And you can do the next slide, please, bit when you're ready.
All right. So all the consent laws have actually been developed over a period of time, but the fundamental element of that is really important to understand. It's about human rights, and there's elements within that which I'm sure everybody will be familiar with because we've heard it in a variety of settings. So that's the right to life, right to be subject to not subject to inhumane treatment. It's the right to liberty and security, a fair hearing, the right to respect for private and family life, and the right to not to suffer discrimination in relation to any other basic rights. So these are big, wide-ranging elements which link into consent. And when we talk about consent, we keep touching on these again, so I thought it was important just to mention that. But in the next slide, I've gone on to slide 3. It's actually about what constitutes consent and what are the big elements around consent that we need to think about. And the first ones are the 3 requirements are for anybody to give consent, they must have capacity and the competence to do so. If that can be established, the person must be able to give their consent as part of their free will, voluntarily and not coerced. And it must be based on adequate information for them to make an informed decision. And that's probably one of the biggest elements that people have some difficulties with. So if we go on to slide 4, I'll go back to what does legal capacity actually mean by that. And I'm sure, again, MD watching or listening has heard those terms. And if we go back to some, again, we're going back to various laws that actually spell out what that is. So presumed capacity in Scotland is anyone under over 16 years. And that's based on the Legal Capacity Scotland Act 1991. In England and Wales, it was previously the MD over 18 years would have naturally have capacity, and that was under the Family Reform Act. But as I'm sure everybody will be aware, under the Children Act, there was big changes around that, and certainly 1985, when we talked about being Gaelic competent. So that's a young person who is under 18 or 16 was deemed then who could give consent because they were deemed to be competent to make that decision. And I'm sure people know about the Gaelic competency. Jeanette, do you want me to discuss that a bit more, or do you think that would be?
I think it's always helpful to know where it came from, Barbara.
Yeah. So Mrs. Gaelic was a bit upset, to say the least, when her daughter, who was under 18, went to her GP to ask for contraception. And the GP followed the outline of the Children Act 1991, who actually said, that's fine if you can, that person who's under 18 can understand what's been said, can weigh up in the balance of what you're telling them, and can make an informed decision about what they want and what they don't want. They are deemed to be competent. They can, they have capacity and competence to make that decision. And the GP treated the said girl. Mrs. Gillick was extremely angry, to say the least, and took umbrage at this and took out a legal action against the GP, saying that he had assaulted her daughter because she wasn't present and didn't have knowledge of the fact that she was asking for contraception. Long and short of it, it went round the houses, ended up at the House of Lords and back, down again. And it was actually deemed that actually the GP had followed the legislation properly and had determined the girl in question was able to consent to the treatment offered. And there was no need for the GP to actually contact the mother to ask permission to treat the girl at that time, which caused huge dissent and discussion around the ability of a doctor to determine that, because the law up to that point had been pretty hard and fast. They're either 16 or over or 18 or over in England and Wales, and that should not be transgressed. So that sent quite a lot of shockwaves through the legal system and healthcare as to who actually had capacity and could consent to treatment without a parent or guardian being present. So as I say, after that, the Gaelic competency element is now there, where people under the age of 16 or 18, if they can be determined as having capacity, can consent to treatment, although they are a minor in the eyes of the law. If you move on then, so that was capacity. Assessing capacity also can be a challenge, and I think that slide, the next slide should be assessing capacity.
I've got assessing competence.
All right, let's go to the next one, which is capacity, and I'll come back to competence.
Certainly.
If you don't mind, that's maybe just that.
Capacity now.
That's it. So people asked for a bit more clarification on capacity, because this capacity seemed to be a bit woolly. And certainly in Scotland, when the Adults with Incapacity Act was brought out, the governing body and the GPs and the health department decided to try and specify a bit more information about how would you assess competence, because people said, well, how does the GP do that based on Gillick competent, and what background and training have they had on this? So there was quite a lot of controversy around that. So the Scottish executives at that time, the Scottish Government Health Department, tried to clarify that. And first of all, they talked about the GP being able to do this. And again, people said, well, how, when, and where? And then they come back with a statement talking about this idea that capacity may vary in adults and for distractions. But again, they talked about the GP or the medical practitioner at that time being able to ascertain whether or not someone was competent by asking them a number of questions, deeming them that they had capacity because of their age, but because of their ability to understand what was being said to them and repeat it, they actually could make a distinction. So if we go back to competence then, because these two go hand in hand, so that was the previous slide, assessing competence.
Assessing competence it is.
Because the law has said when you're assessing if somebody's competent, there's 3 tests you need to ask. You need to say, is the person able to comprehend what you're telling them and retain the information? So you would maybe ask some questions about what you've just told them and make sure they can understand it enough to repeat it back to you. The second question was, and do they believe it? Now that's a bit difficult to ascertain really, because it depends sometimes on how you've explained something to the person, whether or not they understand and believe it to be true or not. But I think they were getting at if someone was actually having a mental health difficulty, they might not understand it if they were delusional, etc. But certainly if they believe it, that to be true, what you're telling them. And thirdly, can they actually weigh it and balance and arrive at a decision? So if you give them the options and the why and the wherefore of it, they can then say to you either yes or no based on what you've told them and what the options open to them are. So that was how they tried to determine how you would actually work out if somebody actually had competence and capacity to make a decision about their care. So if we just go on to the next slide, because it started also within that big discussion and within the Adults with Incapacity Act in Scotland, they started to hammer out a bit more about what is an incompetent patient then. So in doing that, they kind of determined that they went back to the basic tenets of law that no other person can actually consent for you unless it's your legal guardian or parent if you're not, if you're under 16 or 18. They also go back to the legal tenet that if you don't have capacity to do something on your own merit for your benefit, that someone could, and it's usually a doctor, it's now other healthcare practitioners, could actually say to you, they could act in your best interests. And that again went back to a legal case of many years before. where a girl who was had a learning disability. She had her disability meant that she actually couldn't consent to treatment, and she certainly couldn't consent to have a sexual relationship with anyone. And her mother decided that she was at risk of that and determined that this girl required to be sterilised to stop her becoming pregnant within the healthcare institution where she lived. Again, lots of wrangling back and forth, and because the girl couldn't actually determine for herself whether she wanted to be sterilised or not. If you just remember the date, this was 1989. The courts actually took the view that they could actually make a decision on behalf of this girl and sterilise her, acting in her own best interest, which I think today would be a bit controversial, but the decision then, and that wasn't a legal case of F via West Berkshire Health Authority, where it was determined the court could act on her behalf and did so by allowing the mother's request to have this girl sterilised. So quite controversial, and I think if it came up today, there'd be a lot more discussion around that. Another situation where we can act on their best interest without kind of fear of any backlash from that is we're allowed to act in an emergency situation if we think it's a necessary to do so. So out of necessity, if someone's life is threatened, then you can act in their best interest, say performing CPR or any other thing that would maintain their life in a life-threatening situation. And the other element to incompetence that the Adults with Incapacity Act brought in Scotland anyway, is that someone has the right, before they become incompetent, to appoint a proxy person to act in their best interests. And under the Scottish Act, they can appoint someone for their financial, their well-being, their housing, a whole wide range of elements. So it might not be the one person who acts on their behalf or their best interests should they lose their ability to make a decision. But they can do it in a whole range of reasons. And I am currently acting as a welfare advocate for an elderly friend of mine who had sadly developed dementia, but we've known each other for about 20 years or more, and about 10 years ago she asked me to be her welfare advocate, so I act on her behalf at the moment to ensure that her care is actually what it should be. And she's just moved into a care home, and I'm acting with the care home to make sure she gets the best care that she can. So I suppose it's quite useful at the moment to look at the Adults with Incapacity Act, and I think that's the next slide, Jeanette.
Indeed it is.
And that Act has got various elements, but the overall part of it is around the principles of all decisions made on behalf of an adult who is actually incapacitated or impaired capacity must observe the principle of that it must be to the benefit of that person. They must take account of the person's wishes prior to them losing any capacity or competence. And I was able, as I said, to provide evidence of what that person wanted before she actually became ill, and she'd actually committed to paper everything that she wanted as well, which was useful. Any decisions on her behalf need to take account of her previous views, of that person's previous views, as well as got to be practical and reasonable. So I was party to a discussion about going into care, and she hadn't originally wanted that to happen, but unfortunately her care package that she had wanted to have didn't work out because their housing wasn't appropriate. So I was able to express her wishes of what she might want going forward if she couldn't live at home. And we explored the view of she wanted maybe a live-in carer, but unfortunately that wasn't possible either. So that person can indicate to someone who will act on their behalf should they lose capacity for any reason in a variety of elements, and that's in the Adults with Incapacity Act, which is different from England and Wales, which we'll talk about in a bit more. And the next slide talks about what is incapacity in a bit more detail.
Yeah.
And it means the person is incapable of acting or making decisions or communicating decisions about anything to whoever needs to know about it, to their family or friends or medical staff, or with someone for whatever reason can't actually understand the decision. Maybe they've had, as I say, dementia or a stroke, and their ability to understand and communicate their wishes is impaired. Or as my friend is now developing a problem with her short-term memory, she can't remember decisions that she made. So I am recounting to her lawyers and the care home staff what her decisions were previously. Now that's quite a lot. Well, I'll stop there and ask us if you get any questions around that, because there's quite a lot of elements around capacity, incapacity, and competence.
So one of the things that comes up quite a bit at the moment, Barbara, is executive capacity and fluctuating capacity. And I don't know if you'd like to say anything about either of those.
Yes, it's difficult to just determine, and I think fluctuating capacity is the one that people will bring out over and over again. For example, my friend at sometimes can actually answer the questions that I ask her and can tell me what she wants. And then other times when I speak to her, it's as if she's never been asked that question, or she doesn't understand what it is I've just asked her, or what we agreed before. And certainly her lawyers, and she had a period in hospital, and the hospital staff had real difficulty with that, because sometimes she appears very lucid and knows exactly what she wants, and she'll tell you quite clearly. And other times when you ask her the question, she's very confused. So her capacity to decide varies on how she's feeling that day and her memory. And at one point she didn't realise she'd actually gone to the care home and was speaking to me as if she was still present in the hospital. And I had to remind her where she was. And she said, "Oh yes, I understand now." Okay, so that varies from day to day. And the kind of executive capacity is what we all have. We have our own ability to give consent or not to things and make a decision, but sometimes that will vary, and that's sometimes why certainly in the Scottish law they can appoint somebody else to act in that capacity for them. Capacity is a strange word, but in that ability to act on their behalf on that. So you have a fundamental executive ability to do it, but you have fluctuating capacity that moves around depending on, and that's just not to someone who's got early stage dementia. It can be someone who has a number of issues, and the next slide kind of helps identify some of that.
Yeah.
So potential incapacity. So MD over the age of 16 or 18 in England and Wales, who has a problem with decision making, maybe due to a mental disorder. Maybe they're quite deluded, or they're experiencing acute anxiety, or they're experiencing some hallucinations and other mental health issues, which means their ability to rationalise what's happening around about and make a decision is varied, but that might not be all the time. That might be just when they have an acute phase of their disorder. someone who has learning disabilities or other disabilities, again, I'm sure we've all worked with patients with and clients who've got learning disabilities, and depending on how they are on that day, sometimes they can decide some things and other times they can't because their abilities are impaired to understand and work through the options. But in other elements, that's not across the board. In other elements, people with learning disabilities can, with assistance, understand exactly what's happening, what the options are, and make a decision on what they want, what they don't want. So these are not finite things, and incapacity is not kind of always the same. Even someone who has a learning disability or someone who has a mental health issue going on at that time. And again, someone might have problem with decision making, or they can make decisions, but due to something, they might not be able to communicate that very well. Maybe they've had a stroke, or they have lost the power of their hands to write, etc. So the next slide kind of helps with that. It talks about contributions to incapacity. So that can be someone who's got a difficulty with memory, retaining or logical thinking, maybe difficulties in perception. If you're explaining something to a person, and as healthcare practitioners, we often do that. We speak to patients as if they understand all that we understand in terms of medicine and hospital procedures, etc. But if we don't put it in terms that the patient or the client understands, they won't be able to perceive what we're talking about, and therefore can't respond to a yes or a no to certain things because the concepts are alien to them. So it's about how we actually present the information is really vital. Some people, due to their illness or their disability, have real difficulties in, say, planning and making judgments about things, because again, they're not aware of what the options are, or more importantly, what the outcomes of those decisions might be. So it's about, again, the communication in terms they understand, and access to information will help them make that decision. Or someone, say, as I say, who is very depressed, very anxious, or in a very highly emotional state, if we're asking them to make a decision about something at that time, that might not be possible for them to do it at that time, but it could be at another time in the day or later on, once they've had time to think about it and information presented in a different way, they might be able to understand that. And again, as I said, someone who's got a learning disability, or someone who doesn't speak the language that we're using, say English. You know, if we went, say, to France or Germany, or I was in Singapore working for a while, and you know, sometimes my explanation to certain things was not sufficient for people there to understand what I was talking about. So again, a language barrier is always an issue, and we can't assume that everybody first language is English and can understand what we're saying to them. So again, use of interpreter skills, etc., access to this information. Someone who's got a hearing loss or a speech impediment, we need to find ways to help them understand what we're saying, and also to communicate to us what it is they want. So these are just some of the things. That's not an exhaustive element. But
no, so Barbara, I'm looking at that severely disordered emotions, and I'm just thinking, you know, if someone's come in and they've just had a stroke or an MI, and that's what we tell them, that's quite devastating news, isn't it? To be told, you know, you might have had the suspicion, but you always hope that you're wrong. And then when someone tells you actually you have, or as happens with so many people, they come in a bit short of breath, and they, after the chest x-ray or whatever, the doctor says, well, I'm terribly sorry, Mrs. Needs, but what I've seen on your chest x-ray is cancer. I mean, that is just so devastating. I wonder if at that point, when you've had some really bad news from us, whether in that moment people lack capacity as well, because they kind of just freeze up.
Absolutely. And certainly in cancer services now, where there's a multidisciplinary approach, they don't then ask the person to start making decisions on the back of that devastating news. There's usually a time delay, and there's usually involvement of, say, breast cancer nurses or other nurses that will counsel them, support them, allow them process the information they've just been given, and then at a later date, they'll take them through the treatment options, but they're not asked to make a decision about that there and then for that very reason, because they understand they've just been hit by a truck, basically, and then we're asking them to make very serious decisions about what happens next. And I think we've got a bit better about that, but certainly the difficulty is in an emergency department when things are fast moving. The tendency is to want them to make a decision so we can move on to the next section or the next care very quickly. And I think we should be really careful that what we've just told them might well kind of mean that their thought processes are just not logical or lucid at that time. And therefore we might need to say, right, let's get your mum and your family in or whatever, and we'll discuss it with them, and you have time to discuss it with them, even though we're under pressure to get things done, that they actually get some time to think about what we've just told them and give an opportunity to come back with questions or what is the alternative, as opposed to this is what we're about to do.
I think that's kind of something we can do, isn't it, with cancer? But when we're up against a time target with an acute MI, where if you come on, we are going to run out of time in 30 minutes to get this PCI done, or in the old days, the thrombolysis in. It's a really difficult thing, isn't it, not to coerce someone into going, yeah, fine, whatever, when their brain's just grappling with what you've told them.
Absolutely. And that is the danger, that we will be rushing it because we're under pressure of time. But you can put it in a format that people actually understand, and you can say, okay, you're going to have to say, this is what we want to do. There are some side effects around that. This is what we want to do and why, and offer them. So the alternative is what I'm sure the person would say, so if I don't have it, what does that mean? Well, it means actually you have to tell them what the outcome is in a format that they understand. And okay, you're short of time, but you've still got to give that person an opportunity to say yes or no, because they know what the options are and they can weigh that up, just as we said earlier on. So it's trickier when you're in the acute situation to have the presence of mind to just say, well, it's okay for us, but actually if that was me and I'd just been told that, how would I feel? Or how would my family member feel if I just told them that? And take that deep breath and say, okay, I'm going to give you a couple of minutes to think about that. And do you want me to go and get your husband or your sister who's in the waiting room to come and have a chat? And we can get you to talk about that. Yeah.
Yeah, it's so difficult, isn't it?
Yeah.
To make those decisions yourself.
And it's almost you've got to step back and be calm yourself and say, okay, your mind's racing, you want things done, but you're saying, okay, I've really got to step outside here for a moment and just give them that time to come to an informed decision about whether they want the treatment or they don't want the treatment.
Particularly difficult when everybody around you is saying, come on, get it moving, get it moving.
Horrendous. And to be, when you feel you're under pressure from other people, but sometimes you've just got to be the patient's advocate in that situation, say, yeah, people, I know what you're saying, but I'm just going to give, you know, this lady or this man a couple of minutes to just digest what we've just said. And the magic statement always to me, to these people, is if that was your mother or your father, what would you want somebody to do right now? And usually people back off at that point in time and go, okay, right, fair enough. We'll give them that couple of minutes and just, we can be doing other things for them while that's happening. Yeah. Because the next statement's really important. The next slide talks about free expression of will. And that is as a classic case where the person should not be coerced into making decisions by others for their own motives. And it talks about Ray T, and that was a classic case where a girl was pregnant, was involved in a road traffic accident in an A&E department, and they decided that she was in dire straits, and the fetus was in dire straits, and really wanted to do an emergency section on her. She was going to agree to this, but her mother appeared, who was a Jehovah's Witness, and then proceeded to persuade her daughter not to have the section, and claimed that the daughter had been a Jehovah's Witness. Anyway, took a long time of discussion, and you imagine this was in an emergency department, and they were trying to get to theatre, and you could just imagine the chaos that must have been ensuing. And they sought help from the legal advisor, who deemed the medics actually contacted and said, we don't think this is this girl's decision to refuse the section. She was agreeing to the section before her mother arrived, and they presented the case to, it must have been on the phone to a judge, because there wasn't anybody in the research room, I'm sure, at that time, to say that actually she required, first of all, a blood transfusion, and then probably a section as a result of this. And after much discussion and to and fro, the judge actually said that he felt that this girl was being coerced by the mother and not to have treatment, and said that he would act in her best interests, and gave permission for the blood transfusion to go ahead, and then a section thereafter. So, I mean, you think that through in my head. When I've thought that through, I'm thinking that must have been just chaos in there. If that girl was bleeding, they were wanting to transfuse her. They'd started apparently, and then the mother came and stopped it. So I find that difficult to try and work through what that must have been like at that time. However, I had a similar incident some years ago, where I had a child in the research room whose parents were Jehovah's Witnesses, and the child was not of age to have made any decision at all. And the parents were refusing to let us treat the child. And I felt moved enough to actually contact the legal advisor and the social worker, and had a court order placed on the child so we could treat the child, because I felt the child was not in a position to refuse care, and I felt that the parents didn't convince me that this child was a Jehovah's Witness, or that they actually were either. And when I asked them why, they couldn't give me a logical argument as to why they wouldn't treat this child, other than claimed a religious belief. And I overrode that. I went for legal advice and a judgment from a circuit judge on a Saturday night in A&E, and got a court order to care for the child. So that gave me some flavour of what that must have been like in that research room at that time. but not an experience I would want to repeat, I have to say.
No, I can't imagine getting a judge out of bed is everybody's first option of the evening.
No, but I managed to get the uncalled social worker to explain the position, and somehow they obviously know how to act and get a ward of court order on the child. And I spoke to the judge on the phone, explained the position, and he granted us permission to treat the child.
Did the judge talk to the parents as well?
Yes, he did. He asked to speak to them. Yeah, and came back with, having spoken to the parents, I still feel we need to act in the child's best interests, and granted us permission. And that caused a bit of havoc amongst the rest of my colleagues and medical colleagues as well. But we agreed as a team that was the way to go forward.
So why did that cause havoc, Barbara? Was that because the team felt that we should accede to the parents' wishes, or because the team struggled to carry out the judge's orders, knowing that it was against the parents' wishes?
I think a bit of both.
Okay.
I think a bit of both. I think they had never been in that position before, and were parents themselves, most of them, and thought, what would we be like if someone actually made a judgment on our child? You know, really. So, and some of them were also fearful of what would happen after we treated the child. Would they be sued by the parents?
And what did happen? Did you find out?
I think the parents did attempt to take action, but were advised, because of the processes we've gone through that night, and the social worker report, and the judge actually documenting his report, he had given us permission to go ahead. So we did not act unlawfully, and we acted out of necessity to save the child's life, in his view. Therefore, there was no action to be taken against us.
It's always comforting.
It did make us feel a bit strange for a while, I have to say, and I still think back to that day. So it's not a decision to be taken lightly when you are acting on people's best interests when it gets that serious. So the next statement is about, I'll try and catch up here, based on adequate information. Is the next slide. Yeah. And there's two types again. The law doesn't do it easily. It must be, first of all, in broad terms. When you're given information about any treatment option, you must be given it in broad terms about what the intended treatment was going to be about. And secondly, the risks involved. And people, again, get quite concerned about telling people the risks about something, feeling that, well, if we tell them the risks, they'll refuse automatically. So they tend to limit, they're given the broad terms, but they tend not to tell them the risks involved. And I think that is sometimes, you know, we're thinking, well, if we want to tell them all the risks involved, we'd be there for forever telling them risks, because every treatment has a risk. But it's in broad terms, and what are the you must be telling them what are the risks for the treatment and against having the treatment, so that person can understand what they're agreeing to and why, and can challenge you about different things. And the next statement's about, the next slide talks about adequate information again. And it says, I mean, some people say, oh, it's got to be in writing. But that statement and the BMA is actually quite clear in what they said in 2001. Consent can be verbal, written or implied, or acquiesced by a person who understands what has been undertaken. Acquiescence when a patient doesn't know the details of what you're about to do, is unaware of the consequences, they can refuse, does not consent. So they're trying to be quite clear of this idea. You've got to take the time to tell the person what it is you're going to do, and in broad terms, the why you're going to do it, and what the consequences of not doing it, as well as what are the risks of actually doing it. And again, that causes some concern for some people around how much you can actually tell someone.
It's their body though, isn't it?
It,
And their life.
absolutely, absolutely. And sometimes you've got to tell them, you know, for instance, I've been back vaccinating people recently, and the AstraZeneca, you know, vaccine has had some pretty nasty side effects for a small percentage of people. Vaccines can have that in general, but AstraZeneca in particular had problems. So it's quite tricky when you have an AstraZeneca group, because anybody over 40 up to 65 under the current protocols gets AstraZeneca. So you've got to tell them what the side effects of AstraZeneca actually are, and then get them to agree to take it. So that's a tricky conversation to have with them, especially if they've read the media and they're concerned that they might be that 0.2% of people who have cardiac difficulties or have strokes, etc., you know, cerebral bleeds as a result of it. So, but you can't not tell them. And if they say, well, thanks very much, I'm not having AstraZeneca, then you've really got to say, okay, the alternative is you won't have AstraZeneca today, you won't have a vaccine today, but you need to go down the alternative treatment plan to get access to the other vaccines, because the protocols that they're using at the moment specify only specific people can step outside that protocol. But we'll come to that a wee bit more in. So again, in the next one, there's also a duty to warn the patient, and that's what I've just said. And it talks about, when it says about BOLM, which I'm sure most folk know about BOLM in relation to negligence, it's a duty to the doctor, well, healthcare professional, to explain what he intends to do, its implications, in the way in a careful, responsible doctor in similar circumstances would have done. And that was in 1957, they said that, but clearly what you would tell a patient now is a bit more detailed than what they would have told a patient in 1957 about what a careful and responsible doctor or healthcare professional would do, because, as I've just related to you, our understanding of risks has moved on considerably. And if we know what the risks are and we don't tell them, then I'm afraid we would end up in kind of a lot of problems with the NMC or for doctors, the GMC, etc. So there's just a bit of information around duty to warn, a bit more in the next slide. And again, it's older statements, but they still hold true. The duty to warn of procedure was documented in 1981 in a case where the judge there said that once a patient is informed in broad terms of the nature of procedure which is intended and gives consent, it's real. And if you then proceed without that, it's called assault. You know, if you don't get the consent and you go ahead and treat them, that's assault or trespass under the law. But he went further and he said, actually, it must be demonstrated that had the patient, if somebody wants to challenge you, the patient's got to demonstrate that actually, once they've actually had the information, if you told them all the information, they would have refused the care, which is quite difficult for the patient to prove because it's hypothetical. You know, you can't go back and say, I definitely would have refused at that time, but if you didn't have the information at that time, how can you make a decision? So I find that statement a bit difficult to defend, really.
There's a lot of ifs and buts in that, isn't there?
A lot of ifs and buts. And the next
had they had the information, they would have.
They would have, you know, or
they might not have done.
They might not have done. It is hypothetical. You don't know. and to prove that's quite difficult. So that statement was made in 1981 by a judge, but actually, if we were testing that today, you'd need a bit more specific information about what was said and what wasn't said. And that's where documentation comes in here. I think documentation is really important, that if you are consenting the person, you actually should be putting down some, if it's short note form, what is you've actually told them, and what are the risks in what you've told them, and what was their response to that. That's your only record, unless you're videoing or taping a conversation with someone, that you actually said something and they responded, or they challenged you and asked questions around it. So that's quite tricky. There's another few slides I'll just go through, because if you talk about levels of information, and this is where it gets really quite difficult to determine. This is like a can of worms, and that's why I'm saying it's a framework. If you take broad principles, it's fine, but actually when you dig a bit deeper, there's a bit more detail to be had around it, because it's been suggested there's kind of like 4 methods or levels of information we give to patients, and I'll let you have a wee think about that. So the first one is about, the next slide is disclosure 1, subjective or individual physician. Have you got that one?
Yeah, we have that one.
So that is going back again to about 1980, when it's really down to the doctor or the healthcare professional to decide what they're actually telling the patient and the level of risks they're talking about. It's the opinion of the doctor as to what they should disclose or give to the patient in the way of information. And it was talked about, it's part of, at that point, therapeutic privilege of a doctor to determine that. And to talk about the risk. And I think that has really just been discounted. That was what was accepted maybe in the 1980s, but certainly not now would MD accept that it's down just the individual decision of the doctor to decide what's happening. The next level is probably something that people have heard before, is what was determined in the Bolam case, and talk about negligence, where they talked about the objective or reasonable physician. And in that case, they said that the opinion of a reasonable body of opinion as to what should be disclosed by a doctor should follow what the body of opinion is. And the body of opinion, we're talking about what the BMA says, or what the GMC says, or what the SIGN guidelines or the NICE guidelines say, really. That's what they're referring to in the body of opinion. So what does the current literature suggest is the terms of the procedure, the risk involved, and what you should be disclosing to the person on that to allow them to make an informed judgment. And again, I think it's good that's a bit more developed. And it goes back to what was said in the Bolam test, and the test for whether the doctor was negligent or not was the doctor was not negligent, guilty of negligence, if he had acted in accordance with what the body of opinion was at that time. So what the current guidelines and what the NICE standards are, what the College of Physicians or Surgeons say is the right thing to do. If the doctor followed that, they wouldn't be considered to be negligent in following the body of opinion and sharing that information. And that's why I think it's quite interesting if you watch, well, we're not seeing them as much now, but if you're watching the government briefings on vaccinations, etc., at the beginning, if you remember, there was lots of questions around the risk and what the studies had shown, etc. And they were at particular pains to point out, this is what the research says, this is what the data says, saying that this is not what an individual says. They were following that guideline, really, which sometimes can be challenged now, but anyway, that's what they said at the time. The next level of information, disclosure 3, is a bit more tricky, because it talks about the objective or prudent patient, what the prudent patient would want to know. Acceptance of the patients may require more information than the man in the street would. And I think they're getting at there. So say, for example, I've got a medical condition, a particular medical condition, and it requires me to ask more detailed questions about the treatment that I'm about to get, or I've reacted in the past or something. The doctor is duty bound, or the healthcare professional is duty bound to explore that with me. Once I've announced what my condition and problem was, they need to spend time to go into a bit more detail of what the risks would be of that particular treatment in the light of what I've told them. And again, in the emergency situation, that's going to throw up all sorts of issues about time and detail. And then the last one is disclosure 4. It's about giving information to the patient on what the patient wants to know. And it talks about the concept of informed consent, which was first talked about, believe it or not, in 1994, 1914 in a judge in New York, where he was talking about the person owning their own body and therefore having the right to know what's going to happen to them, which was quite far thinking, you think, at the time. So
that was very far thinking for 1914.
Exactly. So they're thinking about much more detailed. And I think that's what the GPs are now telling you, when actually, when they get someone who comes in now, they have got to go through a process of discussion, because people have access to the internet, etc., and will have a much more involved discussion of things, and therefore be much more prudent about the pros and cons of what the options are. And that causes, I think, no little amount of concern that they're fighting against what's on the internet sometimes, which may be valid data and might not be valid data. And again, you know, in emergency departments, you know, patients are coming back with those questions, which presents a whole issue of, do they believe what's on the internet, or what did they believe what you're actually telling them as a healthcare professional? So these 4 models of information disclosure have merit in their own right, maybe except the first one, but actually it presents a much more trickier picture to any healthcare professional that's actually consenting the person to say, yes, it was informed consent. I did give them the right amount of information to help them decide. Okay, so just trying to move on. So as I said, the document, the next slide, the document informed consent that we now bandy about was actually first determined by a judge in New York in 1914. And that's just a wee kind of statement there, which I think still holds true. He said, every human being of adult years and sound mind has the right to determine what should be done to their own body, his or her body. And it was a doctor at that point in time, a surgeon who performs an operation without his patient's consent commits an assault for which there is liable in damages. So that was the first time that idea of what we now call informed consent doctrine was first talked about. And there's been subsequent cases in law to try to standardise the information that you should give patients. And they do talk about identification of potential risk for a procedure. And there was a case there in Chesterfield, Ashford in 2005 in England that determined what that would be about. And they talked about the injury was demonstrated to be the product of the risk of the patient should be warned about. So a person actually was injured in a procedure, and that they knew about that procedure and they knew about that, the risk to the person before they went ahead with the procedure, but they didn't actually share it with the person enough for them to refuse. So I'm afraid there was a real problem for the doctor in that situation, that he had the opportunity to share the risk and it was pertinent to that patient, and he didn't do so for whatever reason at that time. So in law, if you don't consent the person, if you fail to consent them and go through those stages, you would be liable for accusations of assault or battery in Scottish law. But if you don't actually give them the right information and allow them to make an informed choice, the action about you against you would be for negligence in that you didn't take the time to inform them properly. And there's just a few slides there about negligence, which I probably might not want to go into it right now, but negligence, it's got to be a duty of care. Well, we've all got a duty of care. There's got to be a breach of duty of care. So if you didn't consent them properly, or you didn't actually give them the risk, then that probably would be a breach of care. And if they're harmed as a result of your breach of care, duty of care, then I'm afraid you would be found guilty by a court.
I think there's a bit of a lesson there, isn't there, in stick to the guidelines.
Well, it is, but I think it's fair to say that, but as we've just described, Jeanette, the guidelines sometimes are tricky because they change depending on the patient's situation and the environment you're actually working in. And it's about what is practicable and reasonable to do. I mean, I would love to consent everybody and take as much time with every patient as I'm sure you would, as they would want. But frankly, you'd never get anything done. And while you were considering, some people might come to serious harm.
Yeah. Yeah. You have to work.
You have to work with that.
Yeah.
And when challenged, you would probably have to defend yourself by saying, well, this is what I did. This is why I did it. Here's a documented, even in short note form, what I did and why, and the judgment I arrived at. That's your defence against any challenges in the difficult environment that we find ourselves in emergency nursing. The law is the law, but it's a framework, and we as practitioners have got to interpret that law and therefore defend our position that we act in the best interest of our patient if they can't consent for themselves. Any questions about that?
No, don't see a hand up. No, no hands up.
So what I did, I think I've given you two, but I'll just give you one. There's an application where there's a patient scenario there.
Yep.
Clinical scenario 1.
So,
there's that one, or there's two where there's one related to vaccinations, but let's go for the first one and see what we think. So as in the slide, so we're on shift and you're in charge, and this gentleman, 72-year-old Frank Jones, comes in and he's got severe chest pain, his left arm, nausea, sweating. Son and daughter-in-law have been visiting him around the waiting room, and take him out in the research room and you think, okay, we know what we're looking at here. GP had rung and you think, okay, right, so we're looking at MI here, and we put him on ECG and oxygen, etc. So he's not quite fully alert, as we talked about before, given his condition and being 72. And it's quite difficult to communicate with him because he's really deaf and he hasn't got his hearing aid in, so it's difficult to get over to him. So the doctor's trying to do the history and ask them about if there's any contraindications to thrombolysis, what's his previous history, etc. But he can't really communicate with us very well. The doctor tells him that he's had a heart attack, and actually says he's going to speak to his son because he thinks it's probably best to speak to the son because he's not really communicating with Frank. He explains to the son what he's going to do, and and establishes that he's going to give him thrombolysis, yeah?
Mhm.
So what would be your concerns at this point?
He hasn't asked Frank.
Yep, haven't asked Frank
He
yet.
hasn't told him, and he's over 18, so it's only Frank that can consent for himself.
Right. And what do you think he's assumed?
He's also assumed that the son knows Frank's medical history inside out and upside down, and he might not, because Frank might not want his son to know.
Right.
And or there will be things that older people will not have told their children, principally because they don't want to get nagged for whatever reason. If I tell them, they'll only worry, they'll only nag, it'll be awful, so I'll not tell them. So there'll be stuff that Frank has not told his son.
Yeah, but and also the doctor assumes that Frank can't communicate what he wants or doesn't understand maybe what he's saying. So there's an assumption that maybe he's 72, he's anxious, I'll not bother speaking to him, maybe I'll just speak to the son because I'm not going to get anywhere communicating with him, really. So there's a number of things that maybe be going on in that doctor's mind at that time when and approaching the son. So he gives him thrombolysis and introducing himself to Frank, sure he's the correct patient, all that kind of bit, and giving him the drug. The two nurses prepare and check the drug. So maybe reflecting, so what again, should he have stopped at that point? Should he go ahead?
It's difficult, isn't it? Because at this point, the nurses have just been given the prescription and they're getting on, and they're very much aware of the time frame and the fact they have not, there was that minutes mean myocardium thing, and it was drummed into us, wasn't it, with the thrombolysis. The clock starts ticking the minute the ambulance wheels stop outside the door, and you have got this many minutes, and it's really hard to do everything in that many minutes.
That's right.
So I can see that the nurses would be very, very focused on getting that drug in as quickly as possible. And they didn't stop to go, hang on a minute, you haven't talked to the patient.
Yep.
And it also depends on which doctor it is, because, without going off at a tangent on another subject, it's difficult to challenge some people.
Exactly. So the next situation, while the drug is being administered, Mr. Jones becomes drowsy, less responsive, and develops a pronounced left-sided weakness. At this point, the GP rings, see how he is, and the GP informs the nurse that Mr. Jones had a CVA, minor CVA 3 weeks ago, which he'd been treated for at home. It also transpired that Mr. Jones has not seen his son for several months and had not told them about the CVA. So again, what are the issues now? Where do the staff, the doctors and nurses just find themselves?
I feel a negligence moment coming on here, really. It's just it's her heart sink minute, isn't it? You just sit there and you think, oh, my PIN number.
Yeah.
This is going to be awful. And it's that moment of thinking more haste, less speed, isn't it? If we had just taken 2 more minutes, we wouldn't be facing weeks of just horrific unpicking.
Yeah. Well, I'm pleased to say that's a real scenario. It did happen. Mr. Jones did survive, God bless him. But the issue was, there was an incident report, which you can imagine. We didn't consent him. We didn't actually take the time. He had communication difficulties because he'd had a CVA previously. He had hearing difficulties. He couldn't hear what the doctor was saying, and the furore of the research room and all that goes on. So we actually didn't consent him. We consented his son for the procedure, basically, not Mr. Jones. And so thank God he survived. Thank God everything was fine. And there was a whole instant write-up. The patient didn't take it further, and neither did the son, who was pretty angry about the whole thing. But then, you know, the point was with him, I think the discussion was, but the doctor asked you about your father and his medical history, which I think the doctor did. And the son at no point said, well, I haven't seen my father for months and I don't know. He alluded to the fact or suggested he did know and it was actually okay and there was no issues about the treatment. And I think the doctor had explained to the son what he was about to do. But the fact was he consented the son for the father. He didn't consent the father, and he deemed Mr. Jones incompetent, basically.
Mm.
In the heat of the moment, as you say, in the emergency, we talked about the pressure, where you just, you're the top clock's ticking, you're running that protocol down, you think, we really need to do this, it's in his best interest that we just crash on and do this. But it nearly wasn't in his best interest.
No, because he actually had you known about the CVA, he didn't meet the criteria for the thrombolysis and should therefore not have had it.
That's right. So there was a whole inquiry about that, you know, and protocols and consenting elderly patients, even in an emergency situation, and, you know, using relatives for consent. A whole, as you imagine, sloth of inquiry and recommendations come out of that. But actually it made you stop and think that even when you're in a rush, you can't do a hop, skip and a jump.
No.
Okay.
Right.
Is it time for a drink?
It is time for a break.
Short break.
Shall we?
We'll go to refusal of treatment when we'll come back. Yep,
that's grand. Thank you. So we'll have shall we just make it 5 minutes, Barbara, for a quick drink? Would that be right? So
that's fine. That's great.
Back at, oh, hang on, that now my maths has got to be added up. So back 23 minutes past 8. Lovely. Thank you.
All right. Okay.
Barbara.
Oh, hi, I'm back. So I think it's also important to say that I've talked about the Adults with Incapacity Act, but the equivalent Medical Capacity Act in England and Wales has similar principles attached to it in relation to consenting patients and the principles of that. Hello.
Hello, I'm here. I'm hearing you, and we have the first slide of the refusal of treatment.
Okay. Okay. So just to so we're looking at the opposite for consent, and it's all great when they consent, despite its difficulties. We like it when they consent, but when they actually refuse, that causes some real difficulties as well. And I'm going to just try and again show you the framework of which refusal of treatment it is possible, and when we need to interact with the patient. So if you just go back to slide 2, is about again the requirements for competency.
Yep.
So it talks about, as we said, you can be deemed competent to make a decision if you're able to comprehend and retain the information, if you can believe the information, and you can weigh up decision and make a judgment of what you want to do about that, so arrive at a decision. In terms of refusing, there's another kind of recognised framework that certainly law in the UK understands, and there's kind of 5 requirements of that, which is not dissimilar to consent. They talk about the person being able to understand a simpler explanation about the prognosis for treatment and the treatment plan. They must be, to refuse, they need to be reasonably consistent about the specific goals linked to their beliefs. So if they believe that something else is going to happen or not, if they refuse the treatment, they need to be consistent in that, and they must be able to explain that to you. So they're trying to rule out someone who is maybe a bit delusional or having an altered thought process, where they're arriving at all sorts of weird and wonderful explanations as to what will happen or not if they refuse the treatment. They must be able to then tell you and reason out why they wouldn't take the treatment, and again, what will happen if they don't. And they must be able to communicate the substance of that to the practitioner at that time. So, you know, if I don't do this, you know, the space aliens will get me or something like that, or, you know, or some weird and wonderful explanation that doesn't hold with any reasonable thought. And they must be able to understand the practical consequences of refusing the treatment. For example, the example I gave, if the person realised that if they refused the AstraZeneca injection, unfortunately that night with the protocol, other staff weren't allowed to give them any other one, and they would realise they would have to go away, get evidence of the need to get another one, and then come back, and that there would be a delay, and what the consequences of that delay might be for their exposure to COVID. You know, that kind of level of reasoning, rather than some quite strange thought processes of what might happen if they didn't have it. So again, to establish competence to refuse, they must be able to do all of those 5 things. And when we go back to what we said earlier on, if they've got fluctuating capacity or fluctuating reasoning, that then would make you think actually they're not in a position to consent, but not in a position to refuse either. So if we just look at the next slide, it says requirements for competence to refuse treatment in the UK. The 5 conditions must be present over a sustained period, and the individual must pass the standard diagnostic test for competence. So if you've got someone who is responses are differing or changing, or the rationale's changing, it should make you question whether or not they are able to refuse the treatment. However, if they're quite fixed in their own mind about what it is, they can tell you what is going to happen, what will not happen if they refuse the treatment, and they're quite clear on the timescale of it, etc. Then I'm afraid they would deem to be competent to refuse treatment in the UK. So any questions about that? So we're deeming them, they have capacity, and they are competent to refuse because they're competent to consent. Yeah. Yep.
That makes sense.
So there's a few classic cases which has actually led up to has been quite clear that some people can refuse treatment, even though we might not agree with what they're doing. We might think it quite odd. So there's a couple, if we go to the next slide, there's a few standard legal cases that actually have brought us to where we are in relation to that. So the first one was 1992, where, as we talked about earlier on, this girl, after a road traffic accident, had decided she didn't want a blood transfusion and a caesarean section to save her life and the baby's life, because she had become a Jehovah's Witness, and the judge in that situation, who was called, determined that she had been coerced into saying that by her mother, and she didn't have a religious conviction. Now again, how he determined all of that over the phone, I have no idea, frankly, but this idea of there needs to be quite clear lack of coercion for someone to consent to something or refuse. Another case in point was, again, caesarean sections seem to appear really heavily in the decision making. You know, pregnant women seem to be the kind of the centre of some of these decisions about refusal of treatment. And there was another Ray S again, a lady who was pregnant and didn't want a caesarean section. She was quite clear in her own mind it was on religious grounds, and her husband were both clear they didn't want a section, and I can't remember what religious grounds it was at the time. However, again, the medical staff there decided for whatever reason that she wasn't in her right mind, well, because that she was having difficulty with her pregnancy, I don't know, but they actually went to a judge again, and she was deemed that it was, did they think she was preeclamptic or something is what they told the judge anyway, and couldn't make a decision, and the fetus was in distress. And again, her decision to refuse treatment was overruled by the judge, and she had an emergency caesarean section.
Did mother and baby survive?
Mother and baby survived, I think, if I remember correctly. But again, years of court action ensued where she took action against the team for wrongful treatment and assault, because she had not consented to this. She actually refused, but her treatment, her refusal was overruled because the judge was of the view that she wasn't able to retain the information and consider the consequences logically. And her physiological condition of her pregnancy had overruled that. Another one, Ray C, this was upheld, where this gentleman was a mental health patient, and he had an injury to his leg and developed gangrene, and the decision was that they were going to amputate his leg, and despite the fact he was under a section of the Mental Health Act, he was deemed to be competent and have capacity. He was one of the ones who had fluctuating capacity, because at various times he didn't have capacity because of his mental health condition, but at that time he did, and he did not have the amputation and subsequently died as a result of that. But the judge said that after the test had been applied, that gentleman, although under the Sex and Mental Health Act, was competent, was capable of making his decision, and had capacity to refuse.
It's a tricky one, that, isn't it? Because the Mental Health Act can only stipulate treatment for mental illness. It can't stipulate treatment for physical illness. And I think that one can be subtly misunderstood at times.
That's exactly the case. And I've been asked as a mental health practitioner to apply a section to someone by a doctor with them, so he could actually carry out medical treatment on him. And I said, even if I put a section on, you could not do that, because actually that does not apply. So that's a common misconception, that if you put a section of the Mental Health Act on, you've got carte blanche to treat the patient in whichever way you want. And that's never the case, never has been the case. And that's a case in point where that not apply. And then a more recent one, which has caused a lot of controversy. Well, it was recent at that time. It's one of the first things involved in a young girl who was anorexic, and she was refusing to eat. And the doctors actually applied to the courts to get permission to force feed her. And at that time, much controversy, but the judge actually agreed that force feeding her was part of her medical treatment and granted an order to allow her to be force-fed. That was 1994, and I think our understanding of anorexia and treatment of that has moved on, as is refusal of treatment and consent, it moved on, and I don't think that would stand up to any request nowadays. But it just shows you how some of these are set in the time and the understanding of mental health and various conditions, how the law viewed refusal of treatment, which is was always at that point a very medical model approach. And if the doctor said he needed it, the law tended to follow in step and say, well, if the doctor says it, then that must be right, virtually, with the exception of Ray C refusing his treatment. So again, having moved on from that, we started to think of, as we said, consent and refusal of treatment in terms of the Human Rights Act and Adults with Incapacity, Scotland Act, and the Mental Capacity in England and Wales. Was that
2005 Mental Capacity Act.
Yeah, so there was one before that, wasn't there? There was something before that. Anyway.
No, 2005 was the first one.
Right. So I think
and it all follows after that.
That's right. Those two acts have helped us really kind of rethink our care of consent and refusal, and this idea of people's capacity and maybe fluctuating capacity, but competence even to do things that we don't want, and they have the right to do so, even against our better judgment, which is quite interesting.
I've found it's so much easier to practice now that you've got the Mental Capacity Act, because before you knew there was something wrong with a patient, but you only had the Mental Health Act, and therefore if it wasn't a mental illness, you couldn't use that. If they weren't, obviously if they were unconscious, it was easy, but
that's necessity to save their lives. So
that's absolutely so that was nice and straightforward. But you'd know that someone wasn't right, and now we would say they lacked capacity, and you could do nothing about it. And the family would be saying, for goodness sake, you're going, can't, because they're saying no, and yet you knew, and you were just kind of waiting. It sounds awful, waiting for something to change. And I say that to staff now, they're going, but no, it's fine, don't worry, something will change. and then the lack capacity. But it's very, very difficult, a bit hairy when you know that you could help and the patient's refusing and there wasn't a framework, and that really, really does make a difference.
And the next slide kind of says that, because we now recognise the best interest argument that we sometimes have to say, okay, they do understand, we don't agree, and we've got to let them do what they want to do. We can't put Mental Health Act on them to make them do it, but also we can act in their best interests, but there's a process we need to adopt for that. We can't just do that carte blanche either. So, there are a couple of cases. Ray F, West Berkshire, 1989, we've talked about before. It's been talked about, and this idea of sterilisation of a minor, and that's come out that's been happening for a long time, has really made us think, actually, there is best interests, but you've actually got to demonstrate the best interest to a fine degree if you're going to either treat patients against their wishes. There's got to be a real reason why you would do that, and usually it's life-threatening is when you do that. Other than that, you have a problem. And similar, there's a few cases again in the US in the next slide where the same argument was being used for a while about refusal of treatment and surrogate decision making. The Americans were a bit ahead of us because they had surrogate decision making before, and one of the key ones was to remember a girl, Carolyn Quinlan. I don't know if you remember, and it was way back in 1976, and she was a girl who actually had a road traffic accident and had a serious head injury, and she had diffuse brain injury basically, and ended up intensive care, ER, intensive care on a ventilator, and they realised diffuse brain injury, and she was persistent vegetative state, really. And her mother and father intervened and really said that, and again, you've really got to be careful here, but they had said that Karen had said prior to 1976 that if she ever had an accident or an incident like that, she would not want to be treated. Now, don't quite know, but anyway, the parents took the action against the hospital and tried to stop them treating her, who felt they had to continue to treat because, again, it wasn't Karen that was refusing treatment, it was the parents who were refusing treatment on behalf of her, and they felt obliged to continue to treat her because they didn't want to stop ventilation and care for fear, again, of action against them. Anyway, cut long story short, the parents argued the case back and forward to the Supreme Court and back and forth, and eventually Karen was removed from the ventilator and taken home to be cared for by her parents on a 24-hour basis for about 3 or 4 months before she eventually died. But the parents argued the case that it was in her best interest to continue her care at home and not have what they considered to be inhumane treatment with no outcome, positive outcome, continued in hospital. Which was the same argument used in the UK. Remember Tony Bland?
Yeah, I remember that one.
Yeah, so that
he was from the Hillsborough disaster, wasn't he?
That's right.
He was crushed at that, but didn't die. That's
right. He was suffocated and somebody resuscitated him and he had diffuse brain injury. Anyway, that was the case there again. The parents argued to refuse treatment on behalf of him in his best interest because they felt there was no outcome positive for him, and it was inhumane to continue his treatment in a hospital setting with the invasive treatment he was getting, really. So the refusal of treatment idea is of come of age, I think, really, over the years through big cases like that, but the kind of the framework in which somebody can refuse treatment has blown out those legal cases. So I think I went on to
duty to the patient.
Duty to the patient, yeah. So the duty of the patient is always the same, no matter what, from a legal or an ethical perspective, that we have a duty of care, we have a duty to comfort a patient and provide symptomatic relief of pain. We have a duty to save life, as we know, but when the life can't be saved, then there's another duty of care that starts to come in about this comfort and relief of pain. And we talk about now of, especially for babies, and it's come up in neonates who have treatment withdrawn. They talk about it's not sustainable and it's futile treatment. And the argument under the Human Rights Act is that it's inhumane to continue futile treatment on a patient when there's no gain to be had for that person. So the discussions and the argument about refusal of treatment and withdrawal of treatment stem from this idea of best interest for the patient, and our focus are to talk about dignified and humane treatment and inhumane treatment when there's no long-term positive goal for that person. So again, this idea of you have a duty to prevent suffering when the treatment is futile, and that was certainly used in the Tony Bland case, and act beneficently, so in their best interest and not to cause them harm. So the ethical argument starts to come into the law, and in these judgment cases, they talk about the ethics around that as well, about decision making. And then I think, what's the next slide after that?
Duty to public and profession, acts and omissions.
That's right. And we have this idea that we really do need to act appropriately. We need to be responsible for our acts and omissions, and that's where the documentation comes in, that actually we've got to document what we did in the way of treatment and what we have done in the way of the patient refusing treatment. What we've given them, as we said earlier on, in the way of information and options, and the outcomes of that. if they actually refuse to take the treatment we want. So again, that can be quite challenging, especially in a very heated situation like an emergency department. When someone is refusing treatment, and we say, right, we need to respect their autonomous decisions, absolutely. But if their autonomous decision is to their detriment, where does that leave us ethically and legally? What would you say to that?
Have they got capacity? For me, it always comes back to have they got capacity? Because if they haven't got capacity, then I have a duty to act in their best interests because they are deemed unable to make that decision. If they have got capacity, so long as they understand that they could get, so long as they understand what the consequences of their decision are, and they can tell me that those consequences, then actually, do you know what? That's absolutely fine. If you change your mind, feel free to come back. And I have had people come back. They go, "Nah, you were right. I'll do it. I've had time to think about it. I've got my head around it. It's fine."
And so what you've just described is going through the 5 steps of actually make sure they understand, make sure they know the consequences, make sure you've given them the options, make sure they've got capacity to work through that. And even if they decide the answer is no to you, you think, well, at least they've gone through that process. And again, the door's always open for them to come back. I think that's always the basic as well. It's never a closed door. When somebody refuses treatment, no matter what, they can always come back and reflect on that decision and accept treatment at a later date. It's not a kind of a once and forever, decision. And unfortunately, in years gone by, it was a once and forever decision because we applied some policies that were pretty unsavoury about patients who didn't comply with our wishes in emergency departments, which hopefully we've actually got beyond. But it is quite difficult, when people have got quite fixed ideas about getting them to reflect on it and thinking about what are the options for it.
I think it's interesting when you leave the door open for them, because that really nonpluses people a bit. And you just say, well, okay, then fine. That's fine, you can go. There's no need for you to stay. But feel free to change your mind whenever. And they kind of go, well, it's almost like they're really expecting a fight and arguing about it.
Yeah.
And when you just go, well, that's fine, off you go. They're just a bit kind of, oh,
confused.
Right. Well, that wasn't what I expected you to do. But there's no point, is there? And I'm sure everyone on their patch somewhere has a community that doesn't like antibiotics and doesn't like vaccinations and what have you. I know we have on my patch, and I know to look at the address of the patient before handing out antibiotics, and I don't even go to the cupboard to get them. I tend to go to them and go, right, the doctor's prescribed antibiotics. Do you want to take antibiotics? And then if they say no, you go, well, that's absolutely fine, not a problem. And I've saved myself all the hassle of getting them all out the cupboard. But not a problem. But again, do feel free. If this gets worse, come back and you can have them. It's no biggie, just come back. And you know that very often our level of risk acceptance is much lower than the patient's level of risk acceptance.
Yeah.
And that means we're more cautious. We're always more cautious than they are. So that that feels better. But a lot of staff who are less used to that particular area in the county that will be like that just kind of go, what do you mean? You're supposed to give them the antibiotics? No point. They'll take them out, they'll put them in the bin. What a waste.
And I think there is that level of, you know, and when you're in charge of a department and you've got more experience, I think sometimes you do need to have that kind of helicopter view about what's going on. And I didn't have that as a junior staff nurse or a band 5 staff nurse or whatever. That came with experience of what the next step would be for that person, and seeing them on a regular basis, or as you say, understanding what will happen next if you do that. And what you've just done is give the patient options. So you're giving them options for them to choose, and that sometimes will flow them a wee bit. But I found that sometimes when you give them the options, sometimes you know, despite themselves, they'll actually choose the one that you actually wanted to use in the first place.
Yeah,
without
they
a
will.
fight. You know, it's as you say, they're expecting the fight, they're expecting trouble. You say, okay, if that's what you want to do just now, okay, right, right, we're here, we're open 24 hours, you know, feel free. Okay, go away and have a think about it, but I need to go on and I'll see this other patient if that's okay with you. I'm just like, what? Well, you know, it's like, oh, hey, well, if you're going to be like that, I'll just take them, you know.
I'm not being difficult here. It's no big deal if you don't want the antibiotics. Another patient will take them. It's not an issue. Really, it isn't.
That's right. One man said,
it's a bit more of an issue if you're telling me you won't go to theatre when you're bleeding like a stuck pig. That's
something
I'm a
else.
little bit more iffy about.
That's right. And if they've got alcohol and drugs on board and things, that's suddenly that would cloud the judgment. And you say, well, I can't say they actually meet the 5 steps of competence to refuse treatment because they've got so much whatever on board. You can't make that decision. They can't make that decision. So sometimes you've actually got to say, right, we're going to have to act in their best interest because there's nothing else to be done, because it's an emergency situation, it's saving a life, you know, type thing. But some of the other things, it's no big hassle if they decide not to have treatment on that day. And you say, well, okay, well, here's a sling. I've stuck somebody in a back slab and said, you know what, fine, there you go, off you go. I thought when you sober up tomorrow and you realise that's really, really sore, you'll be back in the morning.
Yeah.
I'll just take that hen. One guy came back and said, well, I thought it'd probably make you feel better, you know. Thinking,
yeah, I could feel your pain, mate. It's
a
fine.
lot better that you're back with your back slab and we can actually sort out your wrist and stuff. Or you put on this huge dressing and one man came back and said, you know, I went home, my wife took one look at me and said, well, you get back up that Royal Infirmary, you're no staying here. And I thought, I knew that because I knew his wife. I thought, you'll not go over the door, pal, and you'll be back here. And but
that's fine. She can have that. She can have that fight with him.
That's right.
So much less hassle.
But we're ingrained to be told, and over the years we've thought refusal of treatment's wrong, and we need to act and stuff. And I think there are cases when we do that, we do have to, but actually a lot of the time we don't. And as you say, it's about documenting what we've done, of giving them the options and saying, okay, that's your decision just now. It might not be your decision later on or tomorrow. We're here, fine. But again, I think that's about experience and people feeling confident that they're actually documenting what they're doing, and they can then defend themselves with that and say, I discussed it with this, and again, if they're concerned, speak to the safeguarding nurse, or if you think they've not got capacity, take advice. Don't feel you need to make that decision on your own. Start, you know, taking opinions and saying, right, what is the situation here? Maybe there's another level of expertise that will help you make a decision for your patient, really. But again, I think somehow we've boxed ourselves into a corner and think we're the one that's got to make the decision. You know.
No, it's really interesting. We've had a very interesting case with a husband who claimed his wife didn't have capacity, and he would make all the decisions, except she did have capacity. And we went to some lengths. Her communication wasn't easy, but we went to some lengths to establish it. And we found out what she wanted because we had to structure our questions very differently. Long story short, we've waved the magic wand and magicked her away from him. But then we get a solicitor's letter saying I want. And the reply is, the patient has capacity. We are not under any obligation to answer any further questions.
Yeah. I mean,
Blooming
the
miraculous.
solicitor's letters will come, and it's everybody's right to do so. But if you have followed the framework, if you've documented, if you've given the patient the options, if you've taken the advice as you had done about exploring it with the patient, therefore you've defended the patient and defended your position. And it might not be everybody's cup of tea, but do you know what? But that's life.
It is.
Yeah,
absolutely.
So there is a patient scenario refusal treatment, but I think it's getting a bit late to be doing that now. It's about a 55-year-old man who refuses some treatment. He had some ongoing difficulties. He refused treatment, surgery when he was in hospital. He was in HDU, etc. He became really unwell, had refused, and was on a ventilator. We managed to get him off that ventilator. And a few days later, he deteriorated again, and he had a further perforation. He had a perforated ileus, basically. And after much support, he refused further surgery. So we had quite a long discussion with this gentleman about the refusal of surgery, why he was refusing it. And despite what we were saying, he was quite fixed in his view that actually he didn't want surgery, but we had to establish he really did understand what he was refusing and what the consequences of that would be. And really what I witnessed was a doctor being really graphic in his description and almost trying to bully and coerce the gentleman into having his surgery. I think he believed that he was doing the right thing. He was acting in the person's best interest because he thought the man didn't understand what he was refusing. But he did know what he was refusing. And sadly that it didn't go well for the gentleman. He didn't have surgery. He came back, he had surgery afterwards, and he subsequently died at a later date. But basically, we went through all the intensive refusal of treatment, apart from the doctor, who I think kind of lost it a wee bit, and tried to bully him into having the surgery by threatening him. I think really, we honoured everything that we needed to do for him to refuse surgery, and he did refuse it, and ultimately it cost him.
It's him that had to suffer it all, wasn't it?
Yeah, it took a while.
If I'd been through all of that, Palaver, I think you'd think it was a living hell. And so I can understand him coming to that decision.
Yeah. But as I say, he was in hospital, he'd been back and forth. He knew probably more than we did about what's happening to him. And he was quite clear in his own mind that he didn't want the surgery because he'd had lots of stuff before. And he, in his mind, dying was better than going through all that again. So
fair enough.
What can you do?
Fair enough.
Okay, so I think we've covered quite a lot of ground tonight, really.
We have, yeah, we certainly have. I could almost have done with twice the time, really, Barbara.
Well, yeah, and that's a hop, skip and a jump through a lot of it, but I've given, kind of the case references for folk to go and look up. But I think my partnership is the law and consent and refusal of treatment, like most of the law, it's a framework. There's no definite answers in any of these. And some people want a kind of black and white answer that the law says. And when you actually look at it, the law really doesn't say that. It gives the options and it gives the framework and the possibilities, but it asks you, the practitioner, to apply that and make judgments and ultimately be responsible for our judgments, really, with patients. Because, you know, if we get it right, it's all happy clappy. If we get it wrong, well, yeah, the hospital will have something to say about it. The patient will have something to say about it, probably, if they survive, or relatives. And then maybe the NMC will throw their hat in the ring, you know, with us. So it is complex, but I think most cases are looked on favourably when the person has done the right thing, followed the guidelines, documented, and has demonstrated they've taken reasonable care, even if it didn't turn out well. Really.
Thank you, Barbara. A nice thoughtful session. As I say, I could have done with double the time. I always find legal sessions absolutely fascinating. Could go on and discuss cases at great length, but thank you very much indeed for that. Now, folks, the way it works is that there's an evaluation appears at the end of the session. For those on the live session, I'll put up the QR code so that you can zap that, and that takes you through to, she says, finding it, that takes you through to an evaluation form in one go. Love the zappy QR code. That's fun. There's me looking for it and not seeing it straight away, so I'm hopeful it's on this slide. And then you can quickly zap it, do your evaluation, and then when you submit the evaluation for the session, what happens is that give it 10 minutes and into your inbox pings a what am I trying to say? A certificate that says you've done your CPD. No, that's don't worry. Nobody's sitting there waiting to receive it, and nobody's sitting there just waiting to send you an evaluation form. There's the QR code. So if you zap that, and it'll take you through, and then you'll get your CPD certificate, which says you spent 2 hours being taught about consent and refusal of treatment. And then if your manager's one of those nice managers that's giving you time off in lieu, if you present evidence that you've actually attended the lecture, then that's what you need to do with it. Otherwise, you can file it in your CPD file or your CPD Me portfolio that you have alongside your MFEN membership. And then you can reflect on it later and make sure you've got the lecture ready to weave into your next case review. The lecture is available on catch up. You can watch it as many times as you want. You don't have to be just the once through. So if you need to go back over Barbara's and my arguments about this, that and the other and try and get the nuance of it, you've got that opportunity. Thank you very much indeed. Good night.
Thank you.
I'll stop the recording.